Why it is so? Because we know that the expert have presumed that there will be a tsunami of the cardiovascular disease. Why we are expecting a tsunami or pandemic after this pandemic? Because there is less number of admission during the COVID surge, and there was suboptimal therapy and less clinical visits during COVID surge. And then we know that COVID affects the heart, and this effect on the heart is continuing beyond the patient had recovered. So why there is a decrease? There was a decreased number of admission during the COVID surge, and maybe these patients are now returning now. We have already seen these type of news headlines where they are saying they were have all the heart attacks gone. The hospital report fewer heart attacks. And this was true because in this meta-analysis and systemic review, where you can see that there was almost 25% reduction in the hospital admission of ST elevation myocardial infarction, which is a true emergency in cardiovascular disease. But there was some trend towards the increased hospital mortality. And in Indian scenario, there was it is unpublished data of the CSI sponsored acute MI COVID admission study. This also showed there is a 25 to 35% reduction in hospital admission of ST elevation myocardial infarction. And then why this decrease in the incidence of cardiovascular illness or ST elevation myocardial infarction? It was presumed there was a less reduction in the air pollution and not nitrogen oxide level, which leads to reduction of myocardial infarction. We know that ppm 5 is directly related to the atherosclerosis, and sudden surge in the ppm 5 leads to precipitation of myocardial infarction. Patients or the individual were living at their home, there was less partying, and so there was a less reduced chemical and gustatory trigger for these cardiovascular events. And overall, there was a relaxed lifestyle and there was improved mental and physical health, especially for middle age and the elderly population. Younger population were a little anxious at that time. But important to note, there was underreporting of the cases also. Patients who had myocardial infarction, they were dying at home. They were not coming to the hospital because of the fear of the COVID infections. Apart from this, there was suboptimal therapy was offered to these patients, and there was less clinical visits during the COVID surge. And maybe because of this, these type of patients are returning again, and maybe they are having a worse clinical condition. And we know that for ST elevation myocardial infarction, the choice of therapy is primary angioplasty, and second choice is the fibrinolytic therapy. American College of Cardiology and Society of Cardiovascular Angiography Intervention has placed fibrinolytic therapy as a preferred therapy in a stable myocardial infarction in case during the period of the COVID surge. Because of the contamination, because of the lack of dedicated cardiac cath lab at that time. And then there was Indian guideline which has also suggested that the fibrinolytic therapy can be used instead of primary angioplasty during the COVID surge. And we know that the thrombolytic therapy or fibrinolytic therapy is not a perfect solution for these type of patients, because we know that the PCI is superior in terms of the all reduction, the all-cause mortality, reduction in the rate of reinfarction. There was a reduction in the stroke rates, and we know that in Indian scenario, most of the time streptokinase is being used, which has an efficacy of only 50%. And then the failed thrombolysis patient are now will be coming back to us. And this is a large registry which was published, and that was the European center, 77 centers who are offering the primary PCI in 18 countries, around 6,600. What it shows that there was a 19% reduction in the primary PCI rate. And important to note that in these patients, the ischemic time was more. The patient presenting more than 12 hours, which is the golden period for any revascularization for ST elevation myocardial infarction, patient presenting beyond 12 hours were more in the 2020 compared to 2019. And then the door to balloon time was also increased, which led to the increase in the mortality, almost 2% absolute increase in the mortality of ST elevation myocardial infarction. The heart failure admission were also reduced. they were reduced to the tune of 1/3 in this heart failure unit. And then the cardiac devices implantation, permanent pacemaker, implantable cardioverter defibrillator implantation, they were reduced to almost 20, they were reduced by 25% in this large study. So there was a reduction in the care of the patient, suboptimal care. And then we know that the COVID affects the heart, and after the discharge, what is the effect of the COVID? We'll see in later in few slides. We know that the heart is affected by elevation myocardial infarction, type 2 MI, because there is a supply and demand mismatch because of the hypotension, there is because of the hypoxia, there is a type 2 MI or more in the COVID patient. Increased chances of thromboembolism, it's a hypercoagulative state, hyperrenistic state, which leads to the increased tachycardia, increased demand, and most myocardial damage. And then there is a chance, there are more chances of microemboli, and it's a pro-inflammatory condition, direct viral damage to the myocardium. All these leads to the myocardial injury in form of the myocardial infarction, microinfarction, myocarditis, ventricular fibrosis, and atrial fibrosis. All these may lead to the ischemic cardiomyopathy, non-ischemic cardiomyopathy, subclinical, subsystolic, or diastolic dysfunction. And these fibrosis may be a trigger point for the ventricular tachyarrhythmia and may lead to the sudden cardiac death. And atrial fibrosis may lead to the atrial fibrillation, which has increased chances of thromboembolism subsequently. And then you can see that it's for the non-severe COVID patients who were followed up, and in the cardiology clinic, it was seen that the patient, almost 27% patient these patients were recovered. Almost 27 patients were having sinus bradycardia. Severe sinus bradycardia was present in 7.2%. Troponin was still elevated in 6.2%, and STT changes were present in almost 8.2% of patients. And the 26 patients who reported cardiac symptoms and they underwent cardiac MRI, what this study has shown that almost 58% were having abnormal cardiac MR imaging. And myocardial edema was present more than 54% of the patient. Late gadolinium enhancement, which is suggestive of fibrosis or scar, it was present in 31 patients. And important to note, all the patients who are having abnormal cardiac MRI, they were having abnormal right ventricular function also. This was an interesting study. 54 consecutive student athletes who are coming back from the isolation recovered, and they underwent the MRI examination. All 48 patients underwent MRI. What it showed, echocardiography, what it showed that the pericardial involvement was still seen in 27% of the patients. 16% patients suggest myocardial involvement. Pericardial involvement was seen almost 12% of the patients. And this involvement was more in the symptomatic patient compared to the asymptomatic patients. And this was a very interesting study which was published in January last month. The 26 competitive athletes were imaged, they underwent the cardiac MR imaging. What it showed, it is that 15% had showed evidence of myocarditis. These patients recovered and they were showing the evidence of myocarditis. We know that myocarditis is in patients who are suffering from the myocarditis, they should be offered 3 to 6 months of rest. They should not be advised to take any strenuous activity for 3 to 6 months. And these were the athletes, and they may develop ventricular tachyarrhythmia. They may develop the sudden cardiac death because of these myocarditis and fibrosis. And 8 additional patients were having late gadolinium enhancement suggestive of prior myocardial injury, and this late gadolinium enhancement was much higher compared to the normative population. But we don't know what is the importance of this type of finding in the patients who was suffering from the COVID infections. But we know that the MR is having a very high negative predictive value. If a patient is having negative MR, then we can reassure the athlete that he can undergo his regular strenuous activity and training. This is a very important study published in November. 100 consecutive patients who were recovered, they were not having any cardiac symptoms. They underwent MR examination and they were compared with the healthy control and the risk factor mass control. What they have found that there was a reduced ejection fraction compared to the healthy as well as the risk factor control. They were having myocardial involvement, late gadolinium enhancement, the myocardium, non-ischemic and pericardial much higher compared to the risk factor control as well as the healthy control. Healthy control was not having any late ganglion enhancement suggestive of myocardial scar or ischemia or some active myocarditis. Important to note, this study showed there is a cardiac involvement seen in 78% of the patient, and 60% of patients were having current inflammation, and it was not independent of the pre-existing condition, severity, or overall course of the acute illness, and from the original diagnosis. And the 12 patients had ischemic type of myocardial late ganglion enhancement. 3 underwent biopsy, which showed inflammation, but there was no evidence of viral. Recently, last month presented, this study was published in the fast track by the European Society of Cardiology in the European Heart Journal by Tushar Kotesa. These were the 148 patients who were having troponin positive during the illness. They underwent cardiac MRI examination, but it has showed there was 33 patients were still having evidence of myocarditis. 33 patients were still having myocarditis. The combination of ischemia, myocardial infarction, and myocarditis was also there, and that could be the reason that the troponin elevation during their active phase. And this also led to the various headlines. And what should we do now when we find such type of patients? Important to note that whenever you have a troponin elevation or evidence of myocardial injury, then we should evaluate and the patient of myocardial protocol as per the COVID guidelines. Then a standard post-MI care should be offered. But in the culmination phase, the ECG and echo should be offered, and careful monitoring of the cardiac symptoms should be done, and the risk factor of the cardiac leading to cardiac managed. And then if anything is abnormal, then they should be offered for advanced imaging, echocardiography with brain imaging, and MR imaging with the enhancement. And the patient, most of the time, these patients present with the chest pain, which is very common in this type of patient, but we must differentiate this type of pain, the other musculoskeletal pain and non-specific chest, which is very common in these type of patient. And how should we do? We apply the similar protocol, similar principle, that careful history and examination, and backed by the indicated investigation. And cardiology referral should be sought when there is a uncertainty in the diagnosis and when the patient is acutely ill. Another problem is with the COVID is the acute, it's a hypercoagulable state, and then every patient of the COVID of moderate to severe intensity should receive prophylactic anticoagulation. And the recommendation is coming up that on discharge we should be offering thromboprophylaxis in form of the low molecular weight heparin for 10 to 30 days, and we can consider newer oral anticoagulant agent in place of the low molecular weight heparin. And how long it should be done, we don't know, because we don't know how long this hypercoagulable state will last. But if the patient has diagnosed with thrombotic episodes, then the therapy should be extended as per the site of the thrombus. For example, the pulmonary embolism. In unprovoked pulmonary embolism, we know that the anticoagulation should be given at least for 6 months to 1 year. And then ventricular dysfunction, obviously left ventricular systolic dysfunction, the heart failure should be managed according to standard guideline, offering the therapy of the beta blocker, ACE inhibitor, ARB or ARNI or mineralocorticoids antagonist. For symptomatic relief, we should be offering them with diuretics. And the patient of myocarditis or pericarditis, the intense exercise must be avoided for 3 months, and then young individuals who are very active in their life, they should be advised to take 3 to 6 months of complete rest. And training should be followed with a specific follow-up, and that they should consider with the functional status biomarkers in form of the troponin or BNP, absence of any dysarrhythmia, and the evidence of normal function. Then only they should be given clearance for the activity. There is some guidance from the American College of Cardiology.
Please summarize. Your time is over.
Right, sir. To conclude, so cardiac involvement in COVID is common. It is long-lasting and carry worse prognosis. expect an increased number of patients with cardiovascular disease because of the suboptimal care, lesser admission during the COVID surge, and continued adverse effects of COVID on heart. We should be carefully monitoring the symptoms and offering the ECG and troponin. And if to suspect any cardiac involvement, if there is a suspicion of the cardiac involvement, then detailed echocardiography, including the cardiac MRI, including the late ganglion enhancement, should be done to identify such patient. And individual athletes should be advised to resume sports activity only after careful evaluation. That's all from my side. Thank you very much.